Thank you very much for this kind introduction. I'm really happy to be able to talk to you about the project focusing on the role of microbiota-derived metabolites in pancreatic cancer treatment. I'd like to start with why such studies are needed, and I believe this becomes obvious when we look at the 5-year survival rates of different cancer entities, where a pancreatic cancer sits bottom with only 9%, although over the last years, this has improved to 11%. There's still so much room for improvements. And unfortunately, most of pancreatic cancer patients already have metastasis at the time of diagnosis. And this Kaplan-Meier curve shows the standard treatment that we apply to these patients. And shown in red here, most of these patients, if they are fit enough to undergo intensive chemotherapy, will get the treatment consisting of 3 chemotherapeutics called FOLFIRINOX. It consists of oxaliplatin, irinotecan, and 5-FU, and folinic acid. Compared to a monotherapy shown in blue here with gemcitabine alone, this largely increases the median survival of the patients. However, there's still a lot of room for improvements, since a lot of patients do not really respond to the therapy and die early on after the diagnosis. And for the rest of the talk, I will especially refer to the patients here dying early after start of therapy as non-responders. And what separates these non-responders from the responder patients is not that clear yet. There are a lot of studies focusing on the tumor microenvironment, and they have shown that there is a strong interaction of especially cancer cells and fibroblasts that shape the stroma within the pancreatic cancers and may block the chemotherapeutics from working. Unfortunately, nothing has yet been translated to the clinic, and there's a knowledge gap of factors from outside the tumor microenvironment that contributes to the response we are observing. And one of these factors that could mediate or influence response to therapies is the intestinal microbiota. As we heard before, there's been increasing knowledge on the role of the intestinal microbiota, which can degrade all the dietary compounds that we incorporate and produce a lot of metabolites that either locally influence the immune system or can go via circulation and influence not only immune system, but also the metabolism and also cancer cells throughout our body. The microbiota is known to be different in pancreatic cancer compared to healthy humans. This was analyzed in large studies in the intestine, directly within the pancreas, or especially pancreatic cancers, and also in the oral cavity. However, what was not known is whether also in responder and non-responder patients, whether there are differences in the intestinal microbiota. To address this, we set up a small study and recruited around 30 patients suffering from metastatic pancreatic cancer who were scheduled to receive polychemotherapy. We collected the stool of these patients before the start of chemotherapy and then observed their disease course and defined them as responder and non-responder based on how the tumor shrank on the CT scans or how long they survived on the treatment. From these 30 patients, we were able to analyze 23 because some patients received antibiotics even before the start of chemotherapy, or some were lost due to corona infections. And within these 23 patients that we analyzed, we had 11 responder and 12 non-responder patients. And this PCOA plot shows the gut microbiota composition analyzed by shotgun metagenomic sequencing before the start of chemotherapy. And even before any chemotherapy was applied, we already observed distinct microbiotas comparing non-responder and responder patients. So we asked, is this only a consequence of whatever is going on in the responder, non-responder patient that then leads to a different microbiota signature, or whether the microbiota is actively contributing to the response we were observing? And this we addressed by using gnotobiotic mice as our model, because there you can easily establish a certain microbiota, which in our case was responder or non-responder microbiota. Then we injected KPC cell, which is a marine pancreatic cancer cell line, into the pancreas of these mice and waited some days for the tumor to grow. And then either treated the mice with the same chemotherapy used in humans or let the mice untreated. At day 20, we compared the tumor size of these mice and actually found that in the different experiments using different non-responder or responder microbiotas, we found a response only in the mice colonized with responder microbiota. Here, this is the final tumor weight shown as a relative tumor weight compared to the untreated condition of the same experiment, meaning that if a tumor is below 1, it responded to the therapy. And this was only true in the responder colonized mice. So we asked, how does the microbiota influence such response? And first we analyzed the tumors and didn't find any bacteria present. So we thought, okay, maybe this effect is indirectly regulated via circulating metabolites. And to address this, we collected serum of the responder patients we used for the first experiments, and also the serum of the respective colonized germ-free mice. And then we used the biocrates metabolomic screening kit and analyzed metabolites increased or decreased in responder, non-responder patients and the respective mice. And what we found was that 3-indole acetic acids was increased in both in the serum of responder humans and also in the respective colonized germ-free mice. So let me quickly introduce to you 3-IAA. It's actually a phytohormone, usually present in the roots and seeds of plants, and that regulates cell growth and division, and also the metabolism of plants. For example, here as shown for iron metabolism. And in the human body, you are already familiar now with this scheme. 3-IAA, as shown here, can be produced from the essential amino acid tryptophan via the intestinal, or mainly via the intestinal microbiota. And since it's produced from the essential amino acid tryptophan, we wondered whether dietary intake of tryptophan may even modulate the 3-IAA serum concentration and thereby also modulate the response to the chemotherapy. We moved again into gnotobiotic mice and colonized them with responder microbiota. This is important because for this microbiota, we had already validated that the microbiota is capable of producing 3-IAA. Then we waited some weeks again for colonization, inject the same autotopic pancreatic cancer cells, and then applied a short dietary intervention with tryptophan high, standard, or tryptophan low diet. We cut down the dietary intervention to a very short time interval, since tryptophan can have a very strong influence on the immune system, as we heard in the last talk. And there have been several studies showing that very enlarged and increased exposure to tryptophan high diet may also increase tumor growth on its own. In our hands, with this very short intervention of only 4 to 5 days, we didn't see any negative effect on tumor growth on its own. However, what we observed was that in the tryptophan high diet group, we saw increased level of 3-IAA. And even more importantly, after treatment with chemotherapy, we observed reduced levels of tumors, meaning that the 3-IAA concentration was correlating with the tumor growth. Having seen this, we asked whether 3-IAA might be directly capable of inducing response to chemotherapy. We went into SPF mice because in our mouse barrier, the mice appear to have very low levels of endogenous 3-IAA. And this leads to no effect for the chemotherapy on its own. So this is the final tumor weights at day 20 of a similar experiment. However, if we orally gavaged the mice with 3-IAA and treated the mice with chemotherapy, we saw a strong effect of the treatment, which was not present with the 3-IAA treatment alone. So, of course, we wondered what happens to the cancer cells. And as we heard before, there's been really a lot of literature on the role of indoles to regulate the immune system. So we first characterized tumor-infiltrating immune cells 3 days after the treatment. And by doing this, didn't find any difference in the number of or frequency of tumor-infiltrating T cells or macrophages. We also didn't find any effect on the treatment if we depleted T cells, CD4 or CD4 and CD8s together in either this model where we supplemented 3-IAA in SPF mice or in the responder microbiota colonized mice. However, the only difference we observed was the number of neutrophils infiltrating the tumor, which was reduced in the condition of chemotherapy and 3-IAA. And this was not confined to the tumor microenvironment, since we also found reduced numbers of neutrophils in the spleens of these mice. And going into the literature, we found a clue why this might be the case. So there's been some studies in the 90s testing the role of 3-IAA on rats' neutrophils ex vivo. And what they found was that actually 3-IAA induces H2O2 production. So the accumulation of reactive oxygen species, also called ROS for the rest of the talk. And this was due to the oxidation of 3-IAA via MPO, so myeloperoxidase, which is highly frequent in neutrophils, to a toxic compound called MOI, 3-methyloxindole. And since the accumulation of ROS is also a typical mediator of the efficacy of chemotherapy, we asked whether similarly in cancer cells, we would observe an accumulation of ROS in the combined treatment of 3-IAA and Ferinox. And this was again tested in SPF mice, where autotopic pancreatic cancer cells were injected and 3-IAA and chemotherapy was applied. And ROS levels were measured via fluorescent dyes 6 hours after the treatment. And we found that in the condition of 3-IAA and Ferinox treatment, compared to Ferinox alone, ROS was highly increased within the cancer cells. Having shown you before that ROS accumulation in neutrophils is due to the function of MPO in neutrophils, we wondered whether also MPO is decisive for ROS accumulation in the cancer cells, since neutrophils and MPO are highly present in pancreatic cancers. And we addressed this by irradiating SPF mice and colonizing them with either wild type or MPO knockout bone marrow. After some weeks of reconstitution, we injected KPC cells autotopically and treated the mice with 3-IAA and Ferinox as we did before. And compared to the wild type controls, where we saw a nice synergy of 3-IAA and Ferinox, we didn't observe any change in the tumor size in MPO knockout bone marrow reconstituted mice. And similarly, within the cancer cells of these mice, the ROS levels were largely reduced. To sum up this first part of the talk, I brought this small scheme. So I showed you that tryptophan or dietary tryptophan can be degraded via the intestinal microbiota to 3-IAA. 3-IAA might be oxidized via MPO to MOI. And in the presence of Ferinox and MOI, we somehow have a block in the proliferation of cancer cells. And how this is mediated was unclear until then. So we performed a number of different assays to really analyze what's happening in the cancer cells in the condition of high 3AA and chemotherapy. And this was done basically in the same model I showed you before. So SPF mice treated with chemotherapy plus 3AA or in the presence of chemotherapy low. And we performed protein screening, mRNA sequencing, and IHC stainings, and basically found that in the setting of high 3AA and chemotherapy, we observed a downregulation of autophagy. Just to recap, autophagy, this is a cellular mechanism actually needed to supply energy by degrading endogenous proteins and damaged organelles, especially under stress condition, which is basically the treatment of chemo or the treatment with chemotherapy. And we wondered, is this only a consequence of the smaller tumors that we see that then have lower levels of autophagy, or whether autophagy is really causing the smaller tumors that we observe in our models? And this was addressed using a cellular reporter model for autophagy. Since this is a very dynamic process, you need to have protein tags to allow the readout of the autophagic activity. And this was done by using this GFP-RFP reporter model, or this reporter system, which was transfected into pancreatic cancer cells and supplied by the collaborating group of Professor Kimmelmann. And by analyzing the GFP-RFP ratio of these cells, you can easily read out the autophagic activity. And the lower this ratio is, the higher the autophagic activity is. So we injected these cells into the pancreas of SPF mice, treated the mice with chemotherapy plus 3AA, or we added another condition, which was on top of this, treated with the monosaccharide trehalose. And trehalose induces a kind of artificial starving of the cells, and thereby increases the autophagic activity of the cell. And this was done to really test whether increased in autophagy would reverse the phenotype we were seeing. And to show you that the treatment works, we assessed the autophagic activity of the cells or the whole tumors at the end of the experiment. And again, to recapitulate, the lower the GFP-RFP ratio is, the higher the autophagic activity is. And here we can see that compared to the untreated or tumors from untreated mice, tumors from mice treated with chemotherapy increased in the autophagic activity. However, if 3A was present, autophagy was reduced. And then the treatment with trehalose, as expected, re-increased or re-induced the autophagic activity. And looking at the tumor size of a similar experiment performed with a readout at a later time point that would allow more the measurement of the tumor size, showed that compared to chemotherapy alone, the combination with 3AA decreased the tumor size as expected. However, reinduction of autophagy using trehalose reduced the efficacy of 3A and Ferinox, meaning that autophagy is essential for the observed effect. And this is again summarized here. So I already talked about the first parts. Now we can focus here on the later parts. If 3A is present and MPO is present at the same time, MOI occurs, and in the presence of chemotherapeutic treatment, we see an accumulation of ROS in the cancer cells, downregulation of autophagy, and this finally leads to the stop of proliferation. And reversing either of these, meaning increasing autophagy, blocking ROS by N-acetylcysteine, this is something where I didn't show you the data yet, but this can be found in a manuscript, or using MPO knockout bone marrow chimeras, all of these steps would reverse the efficacy of the treatment. This is super interesting, but everything is really established in marine models. So we asked whether there are some more human data supporting a similar mechanism that might also happen in humans. And therefore, we went back into the exploration cohort and analyzed the serum or the blood counts of neutrophils, lymphocytes, and monocytes. And what we found was that the higher the 3AA concentration is, the more depletion of neutrophils we get. So if you get more right onto this axis, you have less depletion of neutrophils throughout the therapy. And if you're more on the left, you have more depletion of neutrophils, showing that higher 3AA concentration lead to more depletion of neutrophils, which might reflect the effects we also observed in our marine models, which was in contrast to lymphocyte or monocyte counts. And even more important was that we found a strong correlation between the 3AA serum levels and either progression-free survival and overall survival of our patients. And to confirm these findings, we also went into another cohort where we analyzed the serum of patients where we received the serum material from Munich, and also found a nice correlation with progression-free survival and overall survival. And of course, both is based on two relatively small cohorts. We are currently trying to increase the explorative data that we have, receiving more and more samples and establishing better pipelines to measure this metabolite and correlate it with clinical data. And with that, I'd like to thank especially Professor Galliani and Professor Huber for supervising the project and helping throughout and really establishing the environments to perform such projects. A lot of internal collaborators, for example, especially Manuela Pischka, for helping with the metabolomic screening and also the single metabolite analysis. People from my department, Dr. Marianne Zinn, who supported me also throughout the project. National collaborators who are now supplying more and more samples from Munich and Essen, and also international collaborators like Professor Kimmelmann from NYU, who helped with his knowledge about autophagy here and also with providing the cell modules to study autophagy in our experimental models. And I'd like to thank you for your attention, and I'm happy to take questions.